So it gives me great pleasure to announce our next speaker, which is Dr. Chris Coulter, who's going to give us an update on TB. So Dr. Chris Coulter is an infectious diseases physician and microbiologist with a strong focus on mycobacterial diseases, especially TB. He's the Principal Medical Advisor to the Queensland TB Programme, Chair of the National TB Advisory Committee, Director of the State TB Reference Lab, and sees patients next door at the Metro South Clinical TB Service at the PA. Dr. Coulter.
Well, thank you very much for that introduction, and it's a pleasure to be here this evening. My talk is not particularly complex, but I hope to cover some of the basic questions and the appropriate answers. And if you want to get more complex, I'll hopefully leave time for questions at the end. So, how does tuberculosis present? I think we're all familiar that this is most predominantly a disease of the lungs, so pulmonary TB, and the classic chest X-ray appearance might be as such on the screen. So, upper lobe predominance, though not always, airspace consolidation, cavitation, and in the cavities, very high TB bacillary burden. About 2/3 of patients present with pulmonary TB, the other third present with extrapulmonary. Of course, many patients can have both. So there is a protein manifestations of extrapulmonary TB, perhaps most commonly lymph node disease, spinal disease or disease of the other parts of the osteoarticular system, central nervous system disease, tuberculomas and meningitis, particularly in the young, but not exclusively in the young. So how is TB transmitted? Well, it's an airborne disease. It is only spread person to person. There are very rare reports of nosocomial spread from jet aerosolization or jet irrigation of abscess cavities causing spread of TB, but these are rare exceptions. This is primarily a disease that spreads by the aerosols that are produced by coughing, but also sneezing, singing, talking. Now, does everyone who gets infected with TB get sick? And this question is answered by an explanation of the natural history of TB. So when a person inhales the M. tuberculosis bacillus, now, first of all, not everyone gets sick. That's either because the infection was an unsuccessful attempt by the organism, or that in fact, more likely the immune system, both the dendritic cell system and the T cell system, have dealt with the organism and eliminated it. But in some cases, the immune system doesn't deal with that initial infection, and we get clinical disease and so-called primary TB, which can be pneumonic or pleural or disseminated disease, including meningitis. However, in most people, the immune system does deal with the initial infection, and we get a condition of latency or dormancy, where tubercle bacilli are contained within granulomas, usually within the lung, but sometimes elsewhere. Then we don't know whether the body eliminates it or lifelong contains it, but we do know that between 5 to 10% don't deal with it properly and eventually progress to active disease. Now, that progression to active disease is most likely in the first year to 2 years after infection, and particularly in children. It's almost always in the first year. And where do these 5 to 10% figures come from? It's very hazy when you try and get some good data on that. Colleagues in Victoria actually looked at some of their contact tracing data and suggested that, in fact, perhaps the risk of developing active TB after infection was higher, at perhaps 15%. In their cohort, children under the age of 5 years, they were modelled at having 56% conversion from latent TB to active TB. And of course, HIV infection is a good example of where a co-infection leads to rapid more progression of TB. So the risk is about 7 to 15% per annum of progression to active TB if HIV is untreated. So what's the global situation? Well, TB has now surpassed HIV as the single most lethal infectious disease pathogen. Each year, or at least in the global report that's just been released by the WHO, 2017, it was estimated there was 10 million people who were ill with tuberculosis, with 1.6 million deaths. Included in those deaths were about 300,000 people living with HIV. It's a major cause of death in HIV-infected persons, and it's also death is related also to issues of antimicrobial resistance, MDR-TB, XDR-TB, and other forms of polyresistance. The map in the lower part of the slide is estimated TB incidence in 2017. The darker green shading is the countries with higher TB burden, the lighter green, of course, with low TB burden. So you can see that most of the, the Western world, North America, Europe, Australia, New Zealand, and a lot of the Pacific have very low rates of TB, but once we get very close to us, in fact, Papua New Guinea is only about 4 kilometres north of the outermost islands of the Torres Strait, we get very high rates of TB in Papua New Guinea, Indonesia, through many of the Southeast Asian countries into South Asia, and of course in Africa, particularly Sub-Saharan Africa, and to a lesser extent parts of South America. So it is a very important disease globally. Now, if you're seeing patients who have been refugees or are in Australia through the special humanitarian program, they're likely to come from the countries listed on the slide. This is from the Home Affairs website, and figures for 2016-17 are listing the 10 most common nationalities in our refugee and humanitarian program: Iraq, Syria, Afghanistan, Myanmar, Bhutan, and so on down the list. Now, with respect to tuberculosis, how do we make sense of where people come from and their likelihood of being exposed to tuberculosis? Well, just looking at TB incidence as recorded by the WHO, we consider countries that have a TB burden of greater than 40 per 100,000 as being having higher TB burden. And the New South Wales Health Department conveniently puts out each year a summary of the WHO global report, which is a very thick report, and they condense all that down into one pager that tells you all the countries with the greater than 40 per 100,000. That's quite useful. And the stars here are some of those countries that appeared on the slide before as common nationalities in our refugee population. And all of these countries, or nearly all, have rates of above 40 per 100,000, and many of them have very high rates. DRC, 323 TB cases per 100,000 population. Myanmar, 361 cases. Somalia, 270, and so on. Two of the countries that don't have such a high rate, one is Iran at relatively low rates of 14 per 100,000, and Syria at 19 per 100,000. But of course, the refugee journey doesn't necessarily only involve country of origin, and the crowded refugee camps and other interim settlement situations also lend themselves to overcrowding and transmission of tuberculosis. So the risk is often higher in the refugee population than would be indicated by country of origin. So, does Australia have much TB? I usually get asked this at barbecues, and then about 10 minutes later they take their beers and walk off again, because I give them a very good lecture on TB control in Australia. And in fact, after the Second World War, the TB incidence in Australia was around about 55 per 100,000, a little bit lower than Sri Lanka is today. And then there was a national TB program which led to an 80% reduction in TB. Now, if that reduction had continued, we would have eliminated TB by 1990, but that didn't happen. Really since the mid-80s we've had a low but stable rate between 5 and 6 per 100,000. Now this is amongst the lowest in the world, but it's not going down any further at the current time. So who gets TB in Australia? Almost 90% of TB is in our migrant population. So our last published national report was the 2014 report, where we had 1,339 TB cases. As I say, almost 90% of that cohort were born overseas, and of those 1,100 or so overseas-born people, 57 were categorised as being either on a refugee or humanitarian visa. I mentioned that TB tends to present in the first couple of years after acquisition, and interestingly, if you look at the time after arrival for migrants, when do they present with TB, again you have this heavily weighting towards the first couple of years after arrival. It suggests that their infection was relatively soon before they arrived, but there may be other factors. And while there's a very long tail on this number of years to time to presentation or time to diagnosis, you can see that in that first 2 to 5 years is where the bulk of the cases actually are. So if we're going to do something about preventing TB in our migrant population, it's in those first few years after arrival where the best time to do it is. Okay, so what do you do if you suspect one of your patients has TB? Well, consider the pre-test probability, as it were, country of birth, occupation, bearing in mind that those who've worked in healthcare are much more likely to come in contact with TB. Is there an actual history of TB exposure? You'd be surprised how many of the RMOs don't ask this in hospitalised patients who would otherwise be at risk of TB. And do they have any weakening of the immune system would put them at higher risk? The symptoms of pulmonary TB are not particularly complicated. It's usually a cough longer than 2 to 3 weeks, sometimes with hemoptysis, fevers, night sweats and weight loss. Extrapulmonary TB, you've got to think particularly in those under the age of 5 about meningitis and disseminated disease, which will present with fevers, weight loss and failure to thrive. In all age groups, and particularly older age groups, we see a whole protein manifestations of extrapulmonary TB. It can occur anywhere, but and I mentioned some of the more common sites in the first slide. So what tests should you order? The sputum microscopy remains an important test. The slide shows a Zeal-Nielsen stain, although we've now moved to fluorescent stains. And anything that we do a microscopy on, we also do a mycobacterial culture. The upper instrument, that's the Midget 960 MGIT, and that's an automated liquid system, and then below it is a picture of conventional Lowenstein-Janssen media with TB, the sort of buff yellowy colonies growing on it. And in the middle here, this is the Gene Expert. And this has been, in the last 5 or 6 years, an instrument which has been very useful in TB diagnosis, not only here but all throughout the world. So it's a PCR test that within 2 hours can tell you whether there's TB in your sample and whether that TB is rifampicin susceptible or resistant. And rifampicin is a very key drug for treating TB. It does have some issues with sensitivity, and in fact there's a new version that we're trialling in our laboratory at the moment called Gene Expert Ultra, which should come online in 2019. Patients should also have a chest X-ray. Bear in mind that, in fact, when you're screening people for TB, perhaps before starting treatment for latent TB, you can have a normal X-ray and still have TB. So if there's any symptoms, it's important still to do these microbiological tests. Now, the test I didn't mention is the quantiferon, because quantiferon shouldn't be used in the diagnosis of active TB. It's a test for latent TB, which I'll talk about in a sec. Now, we heard in the video concerns about forced isolation for medical reasons. So will my patient be locked away? So in general, we follow the principle TB is best treated at home. In the home environment, people are asked to basically self-quarantine and particularly avoid congregate settings. That's really only for about 2 weeks in most cases, because drug-susceptible TB is rendered non-infectious fairly quickly. If hospitalisation is required, well then respiratory isolation precautions are indicated, usually in a single room, a type 5 isolation room. That's only for pulmonary TB, not extrapulmonary TB. And we do aim to discharge the patient home as soon as reasonably possible with the aim with treatment support. So we have one-on-one case management, which for South East Queensland is managed through the Metro South Clinical TB service next door. There is a process of educating the patient and, importantly, to identify and manage barriers to adherence, because adherence to the TB drugs is very important to, one, have a successful outcome, to prevent drug resistance. And we might also utilise directly observed therapy, but that's not in all cases. Close contacts, particularly household contacts, are routinely screened for investigated for all cases, and depending on the situation, other contacts may also need to be screened. And it's important for your patients to know that, unlike the experience in their country of origin, where TB treatment may not be free, in Australia and Queensland it is free of cost, out-of-pocket cost to the patient. So can we prevent active TB? Well, to go from that, what we don't have is a good test. We don't have a laboratory test that tells us which people who have latent TB are going to progress to active TB. But we do know some risk factors. Recent infection, age less than 5 years, people who have fibrotic scars on their chest X-ray, which is indicative of previous but untreated TB, HIV co-infection and other immunosuppressed states is on the slide. In our setting, renal failure is an important concern, and diabetes mellitus increases your risk of progression by about 3-fold. Alcoholism, malnutrition, silicosis, these are other factors which can be risk factors for progression. It's important to know that latent TB is treatable. In fact, you don't do a test for latent TB unless you're going to offer your patient treatment, because that's the whole aim. The treatments we have reduce your risk of progression by about 80 to 90%, and the options for treatment, well, it's not sort of as easy as 5 days of flucloxacillin, but you can. There are a number of options: 4 months of rifampicin, 6 months of isoniazid. Particularly in children, we favour 3 months of rifampicin and isoniazid together, and this is all daily. But there is a weekly regimen which is dosing isoniazid and rifapentine, which is another rifamycin, on a weekly basis for 3 months. Unfortunately, rifapentine is not available in Australia, so that's a bit of a rate-limiting step. At the beginning of the year, on this slide would have been organised differently. I would have had isoniazid above rifampicin, but in August in the New England Journal of Medicine, there was a large study published which showed that 4 months of rifampicin was equally effective as 9 months of isoniazid, but with a much lower hepatotoxic side effect profile. So quite a few people now are favouring or about to favour rifampicin as their number one choice. And you can read more about our national approach to latent TB in the NTAC document, which is a national position statement on LTBI. So how do we diagnose latent TB? The two tests, as you would be aware, are the MAN2 or the tuberculin skin test and the quantiferon gamma release assays. Sorry, the interferon gamma release assays, such as the quantiferon Gold Plus is the one most commonly used in Australia. The tuberculin skin test has stood the test of time and remains a very useful test. The quantiferon test is somewhat the new kid on the block, although it's been around for quite a while now. And the big advantage of the quantiferon test is, A, it's a single blood test as opposed to a two-step test with a tuberculin skin test. But perhaps more importantly, the specificity is better, because if you've been vaccinated with BCG, particularly in the 10 to 15 years preceding, the tuberculin skin test can be falsely positive, where the quantiferon test is not affected by previous BCG. And NTAC also has a position statement on the use of interferon gamma release assays. Now, who pays for the quantiferon test? This is a significant issue. Up until, I think, last year, the Medicare schedule said it would reimburse for the indication of being immune suppressed. There was never any data produced at the time that MSAC made that ruling that was actually of high quality. There's a lot more data on the utility of the quantiferon test, and I can say that NTAC did approach MSAC or Medicare, arguing that the indications should be fairly broad, that in fact wherever you use a TST, you should be able to have a reimbursable test with the quantiferon test. In fact, not all the indications that NTAC put forward were accepted, and you're probably familiar with the broadened but somewhat limited indications for reimbursement through Medicare. Most of them are related to being immune suppressed or having a risk factor that compromises the immune system. One of the ones that is particularly new to the schedule is that a person has been exposed to a confirmed case of active TB. Now, that is meant to be used for contact tracing. I know that refugee health doctors in Victoria have fairly liberally used that indication on the basis that people who have been in a refugee camp must have been in contact with TB, but that certainly is not the intent of the schedule as it's written. Now, what about the burden of latent TB? So I'm just checking the time in Australia. So my colleagues in Victoria, led by Justin Denholmer, who's the director of the Victorian TB program, have done some modelling based on census figures. They've taken the denominator, the 2006, 2011 and 2016 census data, and modelled what they think the likely burden of latent TB is in the Australian population. Now, at 5.1% of the current population, that's significantly lower than, say, for instance, TB burden in many of the countries of overseas-born people. But it still leaves about over 1 million people in Australia who have latent TB, and the majority of those are untreated. Now, how do you deal with that, both for protecting patients against the subsequent development of TB and also from a public health point of view to overall reduce the burden of TB in keeping with Australia's commitment to the WHO's plan for global TB elimination? This is one example, and it comes from Melbourne. So the Victorian TB program have partnered locally with Monash Health, and they've taken on board local sensitivities and aims and goals, and put together a program for GPs and nurses and other clinicians working in refugee health. It's a training program to help clinicians recognise and then manage latent TB without the need to refer to a specialist. And they also had, as part of their program, an optional sort of 2-hour mentoring session to help build confidence and an opportunity to refine the whole mentoring system. So it's a fairly simple model they have. One, think of TB, do a test for latent tuberculosis. If that's negative, then there's no further action. If it's positive, then it's very important that you exclude active TB by taking a history and also doing a chest X-ray. If either of those are abnormal, then you've got to do the microbiological test, because what you don't want to do is take a single drug that you use for treating latent TB and then treat active TB with that single drug. A, it won't work, and B, you'll just get drug resistance. If you're using isoniazid, as this program is, then the risk of side effects under the age of 35 is very low, and if your liver function tests are normal at baseline, well then go for it, start treatment. But the backup is if you've got a sick patient, if you're unsure, if there's problems with the treatment, well then you can refer your patient for specialist advice. So the idea is that the bulk of patients who would qualify for diagnosis and treatment of latent tuberculosis would be dealt with at the primary care level. And I think that this is something that we have to seriously think about for Queensland in order to improve our management of latent TB and prevent active TB. Now, many of your patients from overseas countries will be very familiar with the BCG, and they and you might wonder, why don't we use the TB vaccine routinely in Australia? Well, the Bacillus calmette-guerin vaccine, the BCG, it's been around for a long time. It was first used in a patient in 1921 as an oral vaccine. It's in a live attenuated form of Mycobacterium bovis. Older members of the audience will remember being tested in schools and if TB naive being given the BCG. But that program ceased in the mid-1980s. Basically, the risk of the vaccine, which was low, was still higher than the risk of TB, which was very low. The TB vaccine, BCG, is not particularly good at preventing adult TB, but it is effective at preventing the most serious forms in children and including preventing death. So our current indications for BCG in Australia and Queensland are in children who are travelling for prolonged periods to high-burden countries, particularly if they're less than the age of 5 years. And in Queensland, we offer BCG to all Aboriginal and Torres Strait Islander children. And one of the lesser-known indications is there's a family history of leprosy. In fact, it's said that BCG is better at preventing leprosy than it is TB. So we give it to family members if there's leprosy in the family. But there have been BCG supply issues ever since 2012. Currently, there is no registered product in Australia. There is an approved product under the Section 19A of the Therapeutic Goods Act. It's a vaccine made in Poland. It's a glass ampule. It hasn't got widespread acceptability amongst vaccine deliverers, but it is used in a number of states and clinics throughout Australia. And how do you know if your patient has been BCG vaccinated? Well, you can go online to the BCG World Atlas, and it tells you what the program is historically in the country of your choice. Here on this map, the pinky purple are countries that used to have a national program but don't any longer. The light green is ones that still have a national TB program. You can see why the BCG vaccine is one of the most widely administered vaccines in the world. You can also look at your patient's left arm, although some countries vaccinate at other sites. This is a BCG scar, which is typically raised. This is a smallpox scar, which is typically depressed, and here showing the classic radiation from the central point. But bear in mind that in some countries, they don't just give one BCG, they give two. So here's a patient who's had smallpox and 2 BCG vaccines. Now, lastly, where can you get assistance? Well, we have a system of TB control units ranging from right next door at the Metro South Clinical TB Service, and a number of our clinical staff are here tonight. And then you can travel right up to the Thursday Island and still get a TB control unit. On the web, from the Communicable Disease Department, we have a web page with lots of useful references and guidelines. If you type into Google Queensland tuberculosis, it's the first hit. We also have fact sheets in a variety of translated languages that might be useful in your own clinical practice. So that's the end of my talk. I gave my watch to my daughter to go to school camp, so I don't know if we've got time for questions or not, but just to acknowledge my colleagues at the Communicable Disease Branch and Justin Denholm for the slides from Victoria. How many patients on active treatment?
How many patients do you have under active treatment at the moment?
In Queensland?
Yes.
Well, I can't tell you the exact number, but it's generally about half the cohort plus a bit extra for drug resistance. So there'd probably be about 110 to 120 patients actively on treatment at the moment, which is less than, say, Victoria and New South Wales, which have bigger burdens of cases.
Sorry, I've got 2 questions. A few years ago, there was for about 6 months of the year, for a couple of years running, there was no BCG vaccine. I'd like to know what is the standard procedure for babies born of fairly recently arrived refugees, or even, refugees who've been here quite a number of years. Are those babies routinely vaccinated?
No, they're not. They used to be. The current policy is to only vaccinate if they're planning travel, usually back to the country of origin, where the TB burden would be higher. If there's been a case of TB in the family, well, then we will usually prophylax the children, particularly if they're young, but we may follow that up with BCG as an ongoing preventive measure. But because even our rates of TB in children are still very low, so that it's just because where your parents are from doesn't necessarily mean you get a BCG vaccine unless there's other risks.
Okay, thank you. The other thing is patients who go to the TB clinic, is it routine for the TB clinic to report back to the GP?
Well, it sounds like there's a point to that question. Certainly if in fact I could probably from the nursing point of view, Paul Blair could probably address that several rows behind you. Certainly from the doctor's point of view, we always write back to the GP who's referred the patient.
We send back the referral forms to the GPs.
Hello, Chris. Chris, with regards to our high-risk migrants coming into Australia and supporting them, do you feel that the TB is actually, the active TB is actually growing? Even though the statistics say we're staying at a certain level, do you feel more and more cases are coming in, that we're coming in with active TB cases?
Well, your possible assertion is correct, but the statistics are also correct. So the population of Australia is growing, and it's growing relatively quickly. And so the actual numbers of TB cases will grow because the population growth is basically not because of people having lots of babies, it's because of migration. So when you've got almost 90% of your TB cases in your migrant population, yes, we will see, and we are seeing, increased raw numbers, but the denominator is also increasing, so your actual rates of TB are staying much the same.
Okay, thank you.
What's the extent of the multi-resistant TB problems at the moment?
Yep. You mean in Australia? Yes. Yep. So in Australia, the rate of MDR TB is around about 1.9, about 2%. It has been higher. If you go back to, say, 2011, it's about 2.4%, and that it was higher previously because of the burden of disease in the Torres Strait, of PNG nationals who are entitled to travel into the Torres Strait because of the treaty that covers that area of the world. So like 2011, I think there was, I can't remember the exact number, but we had a substantial number of MDR TB cases. If you discount the cross-border cohort, which has decreased a lot in the last 5 or 6 years, then the total numbers, it's around about, raw numbers, maybe 30 cases a year, and around about 2%. Now, 2% sounds pretty small, and 30 cases sounds pretty small for a global illness, but it's small because, again, the denominator is small. You know, if you've got sort of a country that has, say, 100,000 cases of TB, 2% is not insubstantial as far as the burden of looking after MDR TB patients.
How do you deal with this group?
Yep. So MDR TB, of course, is a microbiological diagnosis. Once we have confirmed that disease, then we treat, and the treatment is a lot more involved. It goes for longer. You can, in certain circumstances, about in 2016, there was a new regimen called the Bangladesh regimen, which is a 9 to 12 months regimen for MDR TB, was endorsed by WHO. But if you're not using that, then you're going for about 20 to 24 months. The treatments usually have much higher side effect profiles than the traditional first-line drugs of isoniazid, rifampicin, ethambutol, and pyrazinamide. WHO have also recently got us all thinking, because they put out some rapid advice last month, which is for an oral regimen for treating MDR TB, and uses new drugs such as bedaquiline and repurposed drugs such as moxifloxacin, linezolid, clofazimine. And these drugs, look, we're in the laboratory. For most of those, we can't do drug susceptibility testing. They're expensive. It's a sort of a brave new world for MDR TB treatment at the moment, and we're waiting by the end of the year further guidance from WHO. But in general, the principle is you're going a lot longer, you're using drugs that have higher side effect profiles, and traditionally using 4 to 8 months of an injectable, which in Queensland's amikacin.
How do you define the endpoint as to whether the treatment has been successful or not? And do you still use ESR as a is one of your...
No, look, we wouldn't use the erythrocyte sedimentation rate, ESR. No, we wouldn't use that as a marker. Generally, the standard treatment for drug-susceptible TB is 6 months. When do we go longer? Well, one of the tests that's key is to do a repeat sputum examination and culture at the end of the 2-month intensive phase. If that is still positive, 1, will recheck the susceptibilities, and 2, will continue the duration up to 9 months. If someone's got heavy cavitary disease right from the get-go, then we would usually treat them for 9 months. And then various forms of drug resistance extend the duration. How do we know it's working? Occasional radiological surveillance, but in particular that the patient's symptoms get better. They stop coughing, they put on weight, they feel better. Those general bedside things are still really important in TB. So if the X-ray improves, either plateaus or usually improves substantially, the patient's well, and the cultures of their sputum are rendered negative, so you get what's called culture conversion, well then the patient would be classified as having a successful treatment outcome. And by WHO terms, if you do a culture at the end of treatment and that's also negative, you can call it a cure. Okay, thanks.
Thank you very much.
Thank you.